speaker, Dr. Mohammad Hasousah. Dr. Mohammad Hasousah is an associate professor of pediatric and pediatric gastroenterology, consultant pediatric gastroenterologist at the National Guard Hospital, Jeddah, and he is the head section of pediatric gastroenterology at the National Guard Hospital, Jeddah. He will be addressing the issue of eosinophilic esophagitis, management, and update in 2018. So without due delay, Dr. Mohammed.
Assalamu alaikum. Thank you, Chairman. Thanks for scientific committees. I'm very glad to present an important topic to pediatric and adult eosinophilic esophagitis in 2018. I'm going to talk about the clinical definition of eosinophilic esophagitis, what's the difference between pediatric and adult. Then we will focus on update on diagnosis and management of eosinophilic esophagitis. Eosinophilic esophagitis, one of the chronic immune antigen-mediated esophageal disease characterized by symptoms related to esophageal dysfunction and eosinophilic infiltration. The definition in pediatric and adult, usually the symptoms in eosinophilic esophagitis mainly with the reflux symptoms, while in adult usually with dysphagia and food impaction. However, the at least 15 eosinophil per hour per field usually will differentiate from GERD and other eosinophilia problems like parasitic infection, allergic, and others. In this cartoon, we'll show you how the genetics abnormalities and allergy, together with environmental factors, contribute to the causes of eosinophilic esophagitis, including stimulation of the inflammatory markers, leading to acute and chronic inflammation. The number of publications of eosinophilic esophagitis increasing more and more in pediatric and adult. And I'm sure in 2018, you will see more and more. The reason for that, because increased awareness of this disease among the gastroenterologists. This is our first papers in Saudi Arabia in 2011, shows that failure to thrive and eosinophilia and high IgE together with trichalization give index suspicion of eosinophilic esophagitis. The difference between adult and pediatric eosinophilic esophagitis is quite different, including the symptoms. Usually the dysphagia presented with adult, while reflux symptoms presented in pediatrics. The diagnostic delay in adult patient, usually in the adult, usually have long diagnostic delay because of the esophageal mural remodeling, while in pediatrics, usually diagnostic delay will be short. The type of allergy in pediatric usually is food, while in adult, usually due to airway. The endoscopic finding almost similar, but the rings usually presented in adult, while response to eliminated diet usually approved in pediatric, while in adult is not approved. Both pediatric and adult, similar in the male predominance, similar in prevalence of atopies. They have high IgE and eosinophils. However, the immune markers increase in both children and adult, while both of them have response to topical steroid. Molina Infanti found a new spectrum in eosinophilic esophagitis and condition called BBIRE, responsiveness esophageal eosinophilia. They produced it for follow-up for almost 75%. They have achieved remission, and 1/3 of them, they have eosinophilic profile approved by high eosinophil count and endoscopy finding, while 2/3 of them, they have gastroesophageal reflux profile with low eosinophil and pH probe. However, if you see these tables, the difference between eosinophilic esophagitis and BBI, usually the eosinophilic esophagitis and BBI both have the same male predominant, both have the same symptoms, both have the same endoscopy, both have histology finding, but the difference that the cause of the eosinophilic esophagitis is topical steroid, while in BBIRE usually unclear. And the most important finding that they found it is transcriptome panels. Usually they have similar in eosinophilic esophagitis and BBIRE. So they conclude that BBIRE is most likely to be continuum of eosinophilic esophagitis rather than separate entity. Why? Because they have no difference between them clinically and endoscopically, and the Th2 gene expression found both in pediatric and adult. And the most interesting that the BBI reduced the Th2 inflammation in the BBIRE on the same way as corticosteroid, and also the eosinophilic esophagitis will respond to diet, amino acid, and PBI. There is a condition called eosinophilic esophagitis-like disease. It is similar to eosinophilic esophagitis, but usually there is no lesion in mucosal esophagus on endoscopy. The reason because the expression of messenger RNA of the eotoxin, as well as mucin 4 and cadherin 26. And the most important for this disease, that all family had offspring developing eosinophilic esophagitis, and will be exciting to see what's like this disease. So what is the update in eosinophilic esophagitis in 2018? Does the barium esophagogram help in the eosinophilic esophagitis? The answer is yes, because we look for small caliber esophagus and strictures, and the best data shows that if you compare the most important that if you follow up this patient in eosinophilic esophagitis, they have more chance to have small caliber esophagus, and they follow up to 20 years. They found that the percentage of the esophageal strictures is more in eosinophilic esophagitis rather than BBIRE. What's about endoscopic finding? We are sure we'll expect all this finding in eosinophilic esophagitis, including trachelization, white speckles. However, normal endoscopic finding, you may see it in adult up to 10%, while in pediatric up to 30%. So neither sensitive, specific for eosinophilic esophagitis. So not every esophageal ring are eosinophilic esophagitis, because there is a condition called lymphocytic esophagitis, and it is demonstrated by literature that it has similar symptoms to eosinophilic esophagitis, but more lymphocyte infiltration. We are always set with our pathology, not looking only for the number of the eosinophil count. We are looking for retinal big elongation. We will look for eosinophil microabscesses. We are always look for subepithelial fibrosis, as well as dilated intracellular space. This is why in 2018, they will put, we call it eosinophilic histology scoring system, to put stage and grade, and they add basal cells hyperplasia together with this keratosis and eosinophil surface layering. And this is help us to improve the discordance between histology and symptoms. And there is strong data to put this stage to help how the stage and grade of eosinophilic esophagitis. In European gastroenterology guidelines, they prefer at least 4 to 6 biopsy in diagnosis of eosinophilic esophagitis. And in the left side, if you see endoscopic finding including plaque or furrows alone, you will expect high number of eosinophil count. However, if you see rings alone or linear ridging, you need to increase number of the biopsy to give accurate diagnosis of eosinophilic esophagitis, especially if it is proximal, not distal one. Next questions are skin prick test, patch test, and specific IgA antibodies to food are useful in eosinophilic esophagitis. The answer is eosinophilic esophagitis is non-IgE mediated food intolerance, and nowadays skin prick test and specific IgE to food are not useful to identify triggers of eosinophilic esophagitis. The reason, because the positive predictive value and the negative predictive value are low. In adult patients which are sensitized to the grass, pollen, and wheat, didn't respond to elemental diet. And most importantly, they found that when you give monoclonal IgE antibodies, doesn't eliminate the symptoms. And this is in both pediatric and adult. And there is a strong data on experimental data that eosinophilic esophagitis is not typical purely IgE-mediated disease. So they conclude that this is an adult usually is non-IgE mediated, while in pediatric it's still ongoing data to see how the food allergy. Does mast cell tryptase help for staining for eosinophilic esophagitis? Yes, it helps. If you compare eosinophilic esophagitis to reflux esophagitis, the number of the eosinophil count will drop from 50% to 20%, but there are still small numbers, so we cannot generalize to put it as markers for eosinophilic esophagitis. There are non-invasive biomarkers of eosinophilic esophagitis, including eosinophil cation protein, eosinophilic derived neurotoxin, and if you see this data that the median level, yes, dropping from eosinophilic esophagitis to the placebo group, but still eosinophilic count are still the best standard to monitor eosinophilic esophagitis. So they conclude that the non-invasive markers like serum eosinophil count, it will correlate with degree of the esophageal eosinophilia, and the diagnostic accuracy is 0.7. However, total IgE, eosinophil cation protein, eosinophil derived neurotoxin, mast cells tryptase, and other markers are failed to diagnose or monitor eosinophilic esophagitis. The new non-invasive markers, we call it periostin. It is a protein help for migration of epithelial cells. It is one of the promising agent that tissue demonstrating of periostin help to diagnose eosinophilic esophagitis. And if you see the blue bar, that the periostin drop significant before treatment and after treatment, and as well as to compare between responder, post-treatment, and non-responder. So periostin is one of the promising marker for eosinophilic esophagitis in 2018. EndoFlip. EndoFlip, one of the imaging probe, call it endoluminal functional lumen imaging probe. It will see the reduction of esophageal disabilities in esophageal esophagitis. But the problem doesn't correlate with eosinophil count, but the useful of this EndoFlip is to see the predict for food impaction, and it will correlate the eosinophil ring. Other markers like string test, cytosponge are still in use, but are not generalized. And the most important promising non-invasive markers is esophageal biopsy for transcriptome analysis. For gene expression, it is more promising. Ongoing data to see it will help or to replace endoscopy to diagnose and monitor eosinophilic esophagitis.
Dr. Mohammed, you have 2 minutes.
The treatment, topical steroid is still the first line treatment of eosinophilic esophagitis in pediatric and adult. For systemic review and meta-analysis demonstrate that 60% they have remission at least 2 years. And this meta-analysis shows significant symptomatic and histological remission, and other meta-analysis approved or convince us that topical steroid is still the first line of treatment of eosinophilic esophagitis. Recently, they proved that budesonide oral suspension will help not only symptoms, even they help histological markers and endoscopic outcome. So budesonide oral suspension will improve in adult patient. In pediatric, they found that oral viscous budesonide compared to the swallow fluticasone has better histological response as well as changing in recent post and pre-endoscopic finding. BBI still used for eosinophilic esophagitis. The mechanism is block interleukin 13 and improvement of the barrier function and the percentage of response up to 50 to 60%, including clinically and histologically. Another meta-analysis compared between topical steroid and BBI. They found that BBI has probability better in histological response, but they're not reaching the significant p-value. So still the topical steroid has clinical response.
Your
What's
time is up, Dr. Mohammed. If you can finish just in 1 minute.
What's about the dietary intervention? You have 3 types dietary intervention, including elemental diet, 6 food elimination, and allergy-directed test. And they found that elemental diet reached up to 90% on histological response comparing to the others. Recently, in pediatric and adult, they found 2, 4, 6 studies. They titrate the food allergy. First of all, they eliminate 2 food, including milk and gluten. Then they build up to 4 type foods, then 6 fight food. They found that step-up approach, it will help to avoid unnecessary food restriction and avoiding endoscopy. Regarding endoscopic dilatation in children, this meta-analysis shows that perforation, hemorrhage, hospitalization are rare and no death. So they conclude that esophageal dilatation is safe in pediatric and adult. And this is very interesting finding that they found that esophageal diameters and intrabolus pressure are improved after dilatation with BBI. The guidelines for esophageal dilatation by American Gastroenterology, they found that they go by starting slow with slow diameters up to 4 sessions or up to 4 weeks. And after looking for the tear, depending on the symptoms, you may replace by dilatation every 2 to 3 years together with BBI and diet. New medication called rizulizumab, it's anti-leukin 5. It's been promising drugs to help for treatment of eosinophilic esophagitis comparing to the placebo. And another promising drug called QUAX 576 is anti-leukin 13 antibodies. Comparing to the placebo, you will see response rate better than placebo as well as decreasing eosinophil count.
You need to conclude, Dr. Mohammed.
Okay.
We are told to stick to time.
This is adult guidelines. So the BBI usually concluded that usually when you start the patient, histological response, usually do dilatation. If no response, usually you should rule out dilatation. And we have to make sure the alternative treatment for that. And if it is not, maybe elemental diet. Pediatric is almost similar. So my conclusion is eosinophilic esophagitis is a chronic immune esophageal disease with symptoms and esophageal inflammation. The type of allergy in pediatric is usually food, while in adult usually allergy. The BBI, almost the same disease for EEE, and it is non-IgE mediated. Non-invasive markers usually are less effective, and topical steroid is still the first line of treatment, and endoscopic dilatation is safe in pediatric and adult. And this is suggested for the most recent update guidelines in adult and pediatrics. And this is a website for eosinophilic experture for any other diseases, especially eosinophilic esophagitis. Thank you very much.